7 national, international journals respectively. He has published over 600 papers, 17 chapters, and edited 12 books and much more. It's an honor to have you with us, sir. Our second judge is Dr. Shirish Joshi. He is Professor Additional of Pharmacology at Sages Medical College and KEM Hospital, Mumbai. He has over 10 national and international publications and is ex-associate and assistant editor of Journal of Postgraduate Medicine. He has won many professional awards and is the examiner on the panel of National Board of Examination, New Delhi. And he is also the basic medical scientist in MGM Ethical and CBPRC Mumbai. Thank you, sir, for joining us. Coming to the will be given for 4 minutes for presentation. All participants will be given at 4 minutes for presentation and will be stopped with your presentation starts to exceed 4 minutes and will be stopped. This will be followed by judges' questions and comments. This will be followed by judges' questions and comments for a period of 2 minutes to share poster from their side and switch on their mics and camera while presenting. Please use your headphones while presenting internet connection. In case of any technical glitches on the side of the presenter, 1 minute will be given to resolve the issue. If the problem still persists, the participant will be queued up and he if the problem will be allowed to present again at the end if the time permits will be allowed to present again at the end if the time will be scored on the basis of whatever they were able to present. Then the participant will be scored on the. So we'll start with our first participant. Dr. Aditya Moreskar. Can you start sharing your screen?
Start video.
Dr. Aditya.
Hello, my video has been stopped.
Your video has been stopped.
Actually, I'm presenting from Sahil's laptop. So could you just allow?
Yeah, you can share. Wait. Now, are you getting the option?
Yes. The screen is visible?
Yes, it is visible.
Okay. Good evening, everyone. I would like to present my poster.
Hello, I can't see the screen. Hello, Hawra, I cannot see the screen. Chaudhary sir, can you see?
Dr. Aditya, your PDF isn't visible. Your screen is visible, but your PDF isn't visible.
Okay, I'll just check again. Is it visible now?
Yes, it is visible. Sir,
Yeah,
is it visible?
It is visible. It is visible.
Okay.
That's right. Good evening, everyone. I would like to present my poster, First Trimester Vaginal Bleeding and Pregnancy Outcome. Introduction. Vaginal bleeding in the first trimester of pregnancy is commonly seen conditions like spontaneous abortion, threatened abortion, inevitable abortion, septic abortion, ectopic implantation, and hereditary form mode. However, it is reported that 70% of patients will have vaginal bleeding in the first trimester, and still they will continue to have a normal pregnancy. The objective of the study was to evaluate the perinatal outcomes in a group of patients with vaginal bleeding as their complaint in the first trimester to study the incidence of antepartum hemorrhage like placenta previa, abruption, or adherent placenta, and also to see for the maternal and fetal complications in relation to the gestational age of delivery. The materials, it was an observational mixed retrospective prospective study, including all women who presented with first trimester bleeding above 18 years of age. The results were calculating SPSS software. 36% of patients delivered vaginally, out of which 18 were preterm vaginal deliveries and 24 were full-term vaginal deliveries. Out of the total of 200 participants, 116 participants went on to have a normal delivery, whereas the other 88 went out to have an abortion. The proportion of multi-gravida patients continuing the pregnancy was significantly higher than the proportion of primigravida patients continuing the pregnancy. Apart from the 42 who delivered vaginally, the other 68 had to go undergo lower segment cesarean section, out of which 34 were preterm LSCS, 30 were emergency full-term LSCS, and 4 were elective full-term LSCS. And 6 patients had to undergo a cesarean section cesarean hysterectomy due to complications like uncontrolled postpartum hemorrhage and placenta accreta spectrum. Out of the total 116 newborns, 29 required admission in the NICU, out of which the major chunk belonged because of low birth weight. Two neonates had a birth weight of less than 1.5 kg. Neonates born in 1.5 to 2 kg were 13. There were 42 in the birth weight 2 to 2.5 kg and 59 in the spectrum of more than 2.5 kg. The conclusion is that the first trimester bleeding is a predicting factor in terms of maternal and neonatal consequences, and hence it is necessary to increase the knowledge of the pregnant woman for closer observation. Also, we can the patients who come with the first trimester bleeding we can actually decide about the mode and management of delivery for the patient. Thank you everyone.
Judges, questions, please.
Did you calculate sample size?
Yes,
same question, man. Yeah.
So it came to be 200.
And how many did you follow?
So out of the 200, actually 80 patients had come in near the pregnancy, and hence it was done a retrospective among those patients. And the other 120 had a complaint of vaginal bleeding, and then we followed up the other 120 patients. Those who even gave a history of vaginal bleeding had included them in study as a retrospective study.
Is retroprospective? Is there any such study?
Some mixed retrospective and prospective studies.
Okay. It is not scientific. You see, you either have a retrospective or you have a prospective. This is not accepted, I think. Anyway, Dr. Joshi, any points?
You have taken 18 onwards age group. Is there any?
Yes, sir, to avoid, sir. No, sir. So at the maximum age who came to me was of 46 years. The 18 years of age was decided to avoid any medical.
No, because what I think is similar studies must have been done in the past. So I really would like to know what is new in your study or what is novel in your study. Because these kind of retrospective analysis must have been done by many others. So what exactly new you have done in this study?
So the main things that it was done in a tertiary care center. Also, many of the previous studies said they didn't. We couldn't actually see the use of progesterone because mainly the first trimester bleedings get progesterone. Almost all of the patients had got the cases included in my study because it was done like in hardly 2 years before. So it included the use of most of the patients had got progesterone support for the first trimester bleeding, which actually they should get, whereas it was missing in the previous studies, which were like 10 years back.
Okay, which were the most commonly anticipated complications?
Some major complication was of abortion. So there was because 88 patients had abortion, so they were asked to follow up even if they had another episode of bleeding or if they had continuous bleeding. Among the patients with those who continued till pregnancy, the major complications was preterm labor, sir.
Okay, so it is always better to have one primary objective and then 2 or 3 secondary objectives. So that would have made the picture more clear.
So primary objective was to evaluate the perinatal outcomes, sir.
Yeah. Anyway, thank you. Yeah.
Thank you, sir.
So our next participant is Dr. Akshay Gupta. Could you put it on the slideshow mode?
Full screen view.
Hello, am I audible now?
Yeah, you are audible.
Dr. Akshay, can you put it on the
Full screen. Yeah.
full
Okay,
screen?
yeah. Good evening, respected panel and my fellow delegates. I'm here to present a poster on varied presentation of extrapulmonary TB. I have a case series under the guidance of Rathore sir. So extrapulmonary TB constitute about 20% of all cases of TB, and diagnosing it remains challenging because clinical samples which are obtained from relatively inaccessible sites and it may be possibacillary, so the sensitivity decreases. I had patients who were referred to my department of extrapulmonary TB with complications like convulsions, neck stiffness, severe abdominal pain, and knee joint swellings, sudden paraplegia. They underwent initially X-rays, then CT, and some complicated cases we took for MRI. My sample size was 40, and my study time was short for 4 months, and it included the 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 patients from nearby districts. So I had some interesting cases. A patient which was age 1 year came to Dheeraj Hospital with complaints of convulsion and neck stiffness. She had she was on irregular treatment of AKT since 2 months, and she underwent a CT scan for evaluation. On CT scan, we found multiple well-defined hypodense lesions in periventricular region, and in the temporal near Sylvian fissure, um, with peripheral rim enhancement because we did a contrast also. There was prominence of all ventricles, which suggested communicating hydrocephalus, and there was effacement of varae and sulci on and diffuse meningeal enhancement on post-contrast study. It suggested tuberculoid meningitis. Then we took the patient for MRI and we found out a huge tuberculoma which was causing cognitive distress for the patient. We followed up the patient. We took him for the CSF analysis, and late the CSF analysis came and it came out to be TB. She had no past history of TB. There was a second case. It came to our hospital with right knee joint, and patient also complained of fever and weight loss since past 3 months. So on CT, we found there was erosion of the cortical surfaces of distal end of right femur and proximal end of right tibia, and there was there was a reduction in the joint space of medial and lateral compartment, and there was severe erosion. We also found there was soft tissue nodular masses involving tibia, fibula, and distal end of femur. The final and we then we took this patient for MRI, and then we found out that, there were huge uh, collections in the femur and tibia. Later on, when this we sampled and we sent it for biopsy, it came out to be tuberculous arthritis, and it was a monoarticular arthritis. There was no other complaint.
1 minute left.
Another patient which came for with weight loss and abdominal pain. With post commencement of the treatment, the patient presented with a huge abdominal pain. There was extensive abdominopelvic adenopathy, which was and there was very large lymph nodes which were conglomerated, and there was pancolitis. So in my case study, there were 40 patients which had CNS complication. 50% had abdominal complication with malignancies, and only 5% had mono or polyarthritis. We also found a very interesting case of pancreatic TB, which was due to direct spread from pancreatic tuberculoid gastric ulcer. There was another case of a vesicocolic fistula, which presented as pneumaturia. So the conclusion of my study is that extrapulmonary TB is fairly common, but it's very difficult to diagnose. As it affects very
Time
inaccessible
up.
areas. So no single feature cannot be.
Sir, time up.
Okay.
Judges, questions, please.
Shall I say something?
Please.
Dr. Akshay, we appreciate that you have taken efforts in, collecting those cases and diagnosing them on CT, MRI. But my basic question is your title is missing on the slide. Okay, there are no defined objectives. Okay, primary objectives and or secondary objectives. Okay, it would have been better if you have defined some objectives and put it on the slides. And I'm not clear what is the rationale of doing this study. What is the take-home message? What exactly you want to convey by showing all these cases?
So the take-home message is that so CT is uh, very prompt in diagnosing the TB even before CSF analysis or ATT. So we can start ATT initially because many times we give Zn stain and the patient comes out to be negative. We do CSF analysis. CSF analysis is also negative. So uh, so diagnosing it on CT on abdominal CT is we can find ileocolitis or something, and we can start ATT and manage the patient.
But between these 3 or 4 cases that you have shown,
Yes.
is there any difference that you have noticed, or with respect to diagnosis or early detection, or will the treatment modality is different for all those? So it's not very
Treatment.
clear what exactly you want to achieve by.
So we took multiple biopsies, and it finally came out to be extrapulmonary TB. From that perspective, I did my study and collected some cases.
Okay,
Because
Chaudhary sir, you want to say something?
Yes. Now, you have said 40% of patients had CNS complications. What
yes,
is the findings from the literature?
so the findings from the literature, so because of huge tuberculoma formation, the patient can present with sir, it can present with similar symptoms of stroke also.
No,
Any
what I want to know is that is the 50% of extrapulmonary tuberculosis abdominal and 40% CNS. Is that what the literature also says?
So the literature, sir, in my study, we found out in indefinite group of patients, we
No,
found
no,
40% patients presenting with CNS TB, sir.
absolutely correct. What I'm asking is that as far as extrapulmonary tuberculosis is there, the books
Yes,
are saying the how common it is in which organ system.
so there's no specified literature for that. There's no facts and figures that it happens. 40% of it had happened CNS or something. It is
I think you better read up. This is not a uncommon thing. The second point you said is based on CT findings.
You better read.
You can, based on CT findings, you can start ATT.
yes,
Is
sir.
accepted.
So, so we found that most of the patients, when we chronically followed up, they improved.
No, they have
So,
already said that. What I am saying is, does the book say that based on CT you can make a presumptive diagnosis of tuberculosis and start ATT?
so it's so when we did biopsy and we sent the specimen for Zn staining, then there was a conclusive diagnosis, and then the ATT was started. Like in my TB knee case, we found out possibacillary. Uh, uh, so the organism was Zn stain, and then it was a documented proof, and then they started ATT for that.
But
So,
when presented, you said that based on CT findings, we can start ATT. If I'm not mistaken, that is what you stated.
so, in most of the cases, like
So
in tuberculoma,
that conclusion you made based on your experience with these patients, is it?
yes, so but tuberculoma is a very a genuine finding on CNS, and it depicts that it has already disseminated in whole of the body. But but usually it comes negative. So, so based on this, some of the physicians they start ADT, um, and it has shown some considerable
Okay,
improvement.
thank you, thank you. We can have the next presentation.
So our next presenter is Dr. Devesh Bhargude. Dr. Devesh, could you please start sharing your screen? Dr. Devesh. Dr.
Hello,
Devesh Bhargude. Hello.
am I audible?
Yeah, you are audible. Please start sharing your screen.
Yeah, is it visible?
Not yet. It's not yet visible.
Is it visible now?
Yes, it is visible, but
He has
could
to
you
do it.
please
Yeah.
put it on the, yeah, it's visible now.
Okay. Good evening, everyone. My topic for today is a study for clinical profile of heart failure patients in pregnant and postpartum patients in tertiary care center. The introduction of the topic is since cardiovascular causes are the most common non-obstructive causes in maternal death, accounting for almost one-fifth of the total deaths. The most common cardiovascular cause of death in Western countries is congenital heart diseases, while in India, it is rheumatic heart diseases. The obstetric complications like preeclampsia, anemia, preterm labor, and fetal growth restriction further worsen the outcome. In this study, we have analyzed the etiology, clinical features, and the incidence of cardiac failure in pregnancy and the postpartum period, and to assess the obstetric complications for the same. The rationale for the study is prevention and early detection of the heart failure patients had better outcomes, and also the appropriate and prompt management of heart failure improved the mortality outcomes. The importance of preconception counseling in the patients of congenital heart diseases and the rheumatic heart diseases, and also the avoidance of anemia in pregnancy. MGN objectives for the study were study of the clinical profile, determining the etiologies of heart failure, and study of the maternal outcomes due to its laboratory parameters and clinical correlation of the same. Materials and methods for the same. It was a observational prospective study for a total duration of 12 months in pregnant and postpartum women. We studied almost 40 women in the study, and diagnosis of heart failure was done with Framingham's criteria. Result of the study, mean age for the pregnant woman to have heart failure was 29.08 years. Heart failure was most commonly seen in third trimester, and 70% of the females were in during third trimester. They were all the deliveries that happened were institutional deliveries. There were no home deliveries. Gravida 2 was the most common gravida for heart failure patients in our studies. Most of the patients had symptoms of dyspnea, pedal edema, and palpitations, which were seen in almost all the patients, while heart murmur was present in one-fourth of the patients. Spontaneous delivery was the most common mode of delivery, with induction of labor being the second most common mode of delivery. Coming to the signs, tachycardia was seen in almost 90% of the patient, Systolic BP more than 140 was seen in almost one-third of the patient. Diastolic BP of more than 90% was seen in one-third of the patient. Tachypnea with respiratory rate of more than 18 was seen in almost 100% of the patient. Raised JVP was the presentation in 100% of the patients, and 88% patients had crepitations on auscultation. NYHA class 4 dyspnea was seen in 3/4 of
1
the
minute
patients,
left.
with NYHA class 3 and remaining class 3 in remaining 25% of the patients. Most of the participants had 4 to 5 Framingham major criteria present with them, and Framingham criteria of almost 3 of the patients. The most common comorbidity in our study group was hypothyroidism, and the second most common was chronic kidney disease. Chest X-ray showed shadows in 90% of the patients, with cardiomegaly was present in 70% of the patients. 2DA coejection fraction was less than 40% in 30% of the patients. Mean hemoglobin in our study was 10 gram per deciliter. Conclusions of the study is hypertension, that is pregnancy-induced hypertension, and hypertension was the most common cause of heart failure in pregnant and postpartum patients, while postpartum cardiomyopathy, rheumatic heart diseases, and severe anemia were the consecutive common causes. Complications other than heart failure that occurred were hyperkalemia, AKI, sepsis, congestive hepatitis, and cardiorenal syndrome. Risk of both preterm labor
Sir,
and
time
maternal
up.
mortality were increased with advancing age. Thank you.
Judges, questions, please.
Which grade of heart failure actually you have? I mean,
Sir, we actually did the definition of heart failure as per the Framingham's criteria, where the major and minor criteria were present. Major criteria being bilateral auscultatory rails, the hepatojugular reflex if it was present, cardiomegaly, the raised JVP, and minor criteria like bipedal
so
edema,
you have
dyspnea
looked
on
at
exertion.
you have looked at only heart failure, or you have looked at hypertension and cardiomyopathy also as a predisposing. I mean,
yes, sir. We have looked at heart failure with regards to the etiology being pregnancy-induced hypertension, peripartum cardiomyopathy, rheumatic heart disease, and all the rest of the causes that could cause heart failure in all the pregnant and peripartum patients.
Chaudhary sir, you can ask.
Did you do a sample size calculation?
Yes, sir. It was 14 patients. The sample size calculation was basically done with the prevalence of admission in our MICU setup or the ward admissions. And as per that, every monthly, how many patients are getting endured, the sample size calculated to be 40 for the total duration of 12 months.
That is not how you do. It is depending on the prevalence. Anyway, now your sample was 40.
Yes, sir.
Achha. Now, just 1 or 2 points, because
Sure.
you keep presenting in future also. Now, you see, many of the judges will be old like me. And this red color that you have used, most of it is not visible, or it is very difficult to read.
Okay, sir.
Please use contrasting color, white. Against that, you can have black, you can have deep blue. Don't have light colors, then it is difficult to read.
Yes, sir. I'm sorry.
The conclusion is not there in your poster.
So actually, it's there, but it's not visible in the slide. The last conclusion is there.
Achha.
Sir, you can scroll through.
Achha, achha. Yes, conclusion. I can see the conclusion.
It's not getting visible in the.
Okay.
Yeah.
Okay.
You know, it would have been better if you would have defined your endpoints or classified them into objective endpoints and clinical endpoints.
So actually, that is also there.
So that,
just below the rationale, I have mentioned ends and objectives as well. So that got cut off from the
can
slide.
you minimize this? Can you minimize this so that we can have a quick look?
Sir, are you
Or just
presenting
scroll up?
from phone?
Yeah, I'm presenting from the.
So you can just scroll through the, is it a PPT or a PDF?
It's a PDF, PPT. Just a second. Is it visible now?
Oh, the font size is very small. You have to zoom it.
Is it visible now?
No, still it is hidden. Anyway, Hawra, we can proceed to the next presentation. We have got what exactly wants to say.
Yes, sir. Our next presenter is Dr. Khushbu Agarwal. Could you please start sharing your screen? Dr. Khushbu. Yes, your screen is visible. Put it on the slideshow mode.
Can I start?
Yes.
The study is a study of prevalence of discordant couples in study cohort and determine various factors impacting serodiscordance and fertility intentions. Serodiscordance is a term used to define couples in a relationship when one partner is HIV negative. The term serodiscordant couples refers to intimate partnership in which one partner is HIV positive and another is HIV negative. Rationally, there is a significant population of HIV serodiscordant couples who are sexually active in their reproductive age group and continue to desire and bear children, but the data and support regarding the same is scarce. Findings from a study would help put up policies and interventions. It will also help discordant couples to make informed reproductive choices. The aims and objectives were to determine the proportion of HIV serodiscordant couples in the study cohort, along with to study various predictors of serodiscordance and determine fertility intentions in serodiscordant couples. It was a retrospective and prospective observational single center study. Total of 257 consenting males and females of reproductive age group attending the virology OPD was studied. Study parameters included social factors, demographics, HIV history, and staging of the disease, along with other factors. The results of our study were as following. The following four graphs depict the demographics of our study population. The first graph is of the duration of the relationship of a serodiscordant couple, in which we can see that majority of the couple, majority of the people who were studied were of 21 to 30 years of a duration of relationship, majorly being males, around 96 males being in that section. We had a gender-wise distribution in which we can see that majority of the people are males of 40 to 60 years of age group. In the third pie diagram, we can see the emotional response of the partner who is HIV negative to the HIV positive. So we can see that 213 people of the studied population were supportive of their partner being HIV positive. And in the fourth chart, we have the educational status of the people. We can see that 116 people had achieved the primary education and 97 had attained a secondary education. The next four graphs are of the relationship of regarding the fertility desire and the variability. Variable being age and fertility desire showing a significant association. Employment and fertility desire also showing a significant association. Similarly, with education and duration of relationship and response to the partner, in which we can see that age, the lower the age was more of the fertility desire. Employment and financial status, financial security had a better fertility desire. And duration of relationship, lesser was the duration of relationship, more was the fertility desire. And also if the partner was supportive, then the fertility desire tended to increase. And in the third
1 minute left.
In the third charts, we can see that the staging of HIV disease and serodiscordancy have a very positive relationship. That is, if the HIV staging is of a lower stage, WHO staging being 1, or if the CD4 count is higher, or if the viral load is lower, that is the disease is in control, at that point of time, a patient, the couple is more tending towards serodiscordancy. In results, I would like to say that our study cohort had 4,100 active RVD patients who were following up in virology OPD, of which 1,100 were discordant. That is a significant number of 26% of people are discordant. And we can also see that the serodiscordance is mainly related to suppressed viral load. Thank you. That's all from my side.
Judges, can we have the questions?
Dr. Joshi, you can start.
Yes. It's my question, like if you are the treating physician for this discordant couples, and if they have fertility intentions, what would be your advice to them?
So actually, if I am looking at a male person who is positive and a female who is negative, so the options of sperm washing are available for the male partner, and intentional conception are available. Artificial insemination can also be an option after sperm washing. These are under studies. We do not have a randomized controlled trial to prove what is beneficial or not, but they have shown positive results, and we have not come across the positive children out of this treatment method. Other way around, when the female is positive and a male is negative, we do not have a lot of variation in this setting, because we can just start the female on ART regimens and hope for the best.
Have you calculated the sample size?
Yes, sir. In our sample size, we used the equation of NZ wala.
So this was only at one center, or more than one center was included?
So we use the prevalence as 50%, as India being a higher prevalent HIV state. So serodiscordancy in the studies available was shown to be 50% in the states with higher HIV prevalence. So we used that as
And what is your style of referencing, that references you have put? Can you name some referencing styles which are used commonly?
one poor style.
Yes, that is one. Any other?
No, sir. No,
And
no.
again, conclusion is missing from your slides. So there is no conclusion.
So the results are what I would like to conclude.
Anyway, over to Chaudhary sir.
I think most of the questions are covered already. See, references, there is Vancouver style or there is Harvard style. Follow one standard style.
Yes.
I think you have copied from PubMed probably, because that year and the month is in PubMed. The month is not written in Vancouver style. Good study, but see, you must put these points, conclusion is very, very important. You can't say results is the conclusion. Thank you.
Thank you, sir.
So our next participant is Dr. Pooja Londhe. Could you please start sharing your screen? Dr. Pooja.
Please go to full screen mode.
Hello.
Hello,
Hello.
yes.
Am I audible?
Yes, you are audible. Yeah, you are audible.
Hello, everyone. This is Dr. Pooja.
Your slide is not visible.
Okay, wait a minute. Yes. Here, it is about study of clinical profile of patient with adult onset seizure disorder. Seizure is paroxysmal event due to abnormal, excessive, synchronous electrical activities in the brain. Adult onset seizure disorder is a major public concern and it is one of major burden of a disease. It is affecting various population, but here I have focused on the adult onset, meaning thereby the age group more than 18 years. The causes which we see in different age groups are different. In this adult onset seizure disorder, the causes are mainly CNS infection, trauma, cerebrovascular accident, metabolic disorders, and drug. These causes are different. These are identifiable causes, and these are treatable causes. If we properly evaluate it, and this, if promptly treated, can be resulted in a positive way. While seizures occurs in a children are commonly because of an idiopathic causes, but here the causes are identifiable. Etiology and clinical profile of seizures in adult necessitated decision about initiation and discontinuation of pharmacotherapy that are different from those in a younger patient. And regarding aims and objective, main aim is to study the clinical profile and prevalence of patient with adult onset seizure disorder, to study the etiology of seizure in a patient with adult onset seizure disorder, to correlate the risk factor and predisposing event with the seizure, to study outcome of patient with adult onset seizure disorder. Now, this study is observational prospective study. After obtaining permission from institutional ethics committee and after taking informed consent, study was conducted. It was of around 18-month duration, wherein the sample size was collected. Around 89 was the sample size, wherein patient who are having history of seizure with the age onset of 18 years old, those who are coming for a follow-up in a OPD, or those who are there admitted in a ward having new onset seizure with the age group more than 18 years were enrolled in this study, and these patients were evaluated further. In this study, I divided the population into two under adult onset seizure disorder, that is younger adult and elderly adult. Younger adult are those which are in between 18 to 35 years old, and elder adult were those which were more than 35. The causes were different again accordingly. The study was evaluated. The summary is given in the form of pie and bar diagram. Pie chart, the first pie chart, which is a suggestive of the gender. The maximum were that is male population 55%, and female, that is 45% population. After seeing the prevalence of seizure in particular age group, this bar diagram was shown, wherein the second bar, which was the highest
1 minute left,
which is of age group 25 to 30, was showing highest prevalence. Conclusion of the study, the most common age group of adult onset seizure is below 40 years with male predominance. Generalized tonic-clonic seizure was the most common presentation. Among this, that focal seizure, the most common was focal seizure with secondary generalization. The most common cause was infection. Among this, that it was CNS infection. Since we are in India, TB is the most common cause, followed by stroke. Again, in stroke, in fact, was more common than the hemorrhage. The status epilepticus was not that prevalent in our study. So it is very crucial to study adult onset seizure disorders differently, since the causes are different, are identifiable, are treatable promptly. Thank you.
can we have the questions, please?
Yeah, again, your conclusion is not visible on the slide. I have
so conclusion. Sorry, sir. The conclusion, the most common age group paragraph, it was conclusion. It is somewhere hidden below that diagram. Sorry, I did not see it. That was the conclusion of study.
See, you have taken as a broad, seizure disorders. So have you calculated the sample size How much
Yes,
was
sir.
how much was the sample?
89 was the
And,
sample size.
and what was your age group actually?
So the study says adult onset seizure disorder. So it was starting from age group of 18 year. 18-year age group means those patients who are known case of seizure disorder with the age onset of 18 years, or those who are new onset seizure disorder with the age group more than 18 years. Those who are having any kind of seizure, like it could be a focal seizure, a tonic seizure,
No,
generalized
that is
tonic.
fine. So you have taken, because in one line you have mentioned most common age group is below 40 years. So have you
Yeah,
taken
according to
it
the
from
study.
18 to 40, or even if you
Yes,
have
sir.
taken patients beyond 40 years of age?
No, this bar diagram dictate, if we zoomed it, the bar diagram dictate all the different age group, like starting from 15 to 18 to 20, 21 to 30, 30 to 40. So amongst that, the maximum peak was at 21 to 30.
And you have taken female patients also?
Yes, sir. I have taken female patient as well as male patient. It was a random selection, but according
And
at the end of the
remember,
study, it was
you said that you have taken ethics committee permission, but that EC permission, it is always better you quote that reference number in your presentation.
yes, sir.
EC
Yes, sir.
approval
Sure.
number. And
Yes, sir.
on the slides, your font size is very, very small. So you have to make sure that the font
Yes,
is
sir.
adequate enough to be readable. Okay?
Yes, sir. Yes, sir.
And I mean, it's in all color and all this is in one this. And it looks like you have pasted the diagram onto some of the slides. So I could see some of the material hidden behind the.
Yeah.
I mean, you have to be careful. Again, the references, you have written it like a paragraph. Okay, it should come one after the other. Okay, in a
Yes, sir.
particular sequence, say from newest to old or old to new. Okay,
Yes, sir.
so these
Yes,
are
I'll
my
consider
views.
it.
Over to Chaudhary sir.
Puja, good study, but presentation leaves much to be desired. I'm sorry.
Yes, sir. Yes, sir.
If the presentation should have been better organized. You have to make maximum use of the space. You can,
Yes.
Especially the background you can minimize so that
Yes, sir.
points are covered. Huh?
Yes, sir. Yes, sir. I'll see. I'll take it into consideration.
Right. Thank
Thank
you.
you.
So our next participant is Dr. Rahul Sonavre. Could you please start sharing your screen? Dr. Rahul, are you there?
You can go to the next presentation if it's not available.
Am I
Okay,
audible?
so yeah, you are audible. Could you please start sharing your screen?
Actually, I'm not able to share my screen.
There is a option below share screen, so you have to click on that.
Actually, it is not supporting.
Okay, so till that we can move on to our next participant.
Hawra, my suggestion is you
Yeah.
tell all the participants to send them the slides to you, and you can share it from your end.
Yes, sir.
That will save time. Yeah.
Dr. Rahul, have you shared your presentation with us?
Yes, I have shared it.
Okay, so I'll share it from my side. Is it visible?
Yes.
Okay, so you can start.
Good evening, everyone. This is Dr. Rahul. Introduction. Dengue is a breakbone fever endemic in tropics, is probably most common arthropod-borne viral disease worldwide. Organ involvement in dengue with most common systems being bone marrow suppression, hepatic, renal, subsequently with gastrointestinal, cardiopulmonary, central nervous system, DIC with hemorrhagic syndrome, and extremely rare incidence of eye and thyroid involvement. For the classification of various organ involvement, liver involvement refers to high titer of alanine aminotransferase and aspartate aminotransferase beyond 1000 international unit per liter or acute liver injury. Kidney involvement refers to acute renal failure or acute exacerbation on chronic kidney disease. Heart involvement refers to myocarditis, pericarditis, and or heart failure, while central nervous system involvement refers to encephalopathy, encephalitis, as well as intracranial bleeding. Aims and objectives: to study the clinical profile and impact of organ involvement on outcome of dengue patients, to study laboratory profile of dengue patients with organ involvement, and to study the impact of pre-existing comorbidities and other risk factors on organ involvement among the dengue patients. Materials and methods: we conducted observational study on 138 diagnosed cases of dengue fever in tertiary healthcare center. The study lasted for 18 months after IC approval. Results and interpretations: liver was the most frequent organ affected in this study. There were 106 patients with hepatic involvement and 101 were discharged and 5 died. 36 patients were having renal involvement, out of which 30 discharged and 6 died. Renal involvement in patients of dengue is significantly associated with death. Out of 21 patients with pulmonary involvement, 19 were discharged and 2 died. Pulmonary involvement does not significantly affect patient outcome. There were 19 patients with combined renal and hepatic involvement, out of which 15 discharged and 4 died. Hence, presence of combined hepatic and renal involvement in patients of dengue is significantly associated with deaths. Out of 30 patients with serositis, 29 discharged and 1 died. Hence, presence of serositis does not significantly affect the patient outcomes. Conclusion: we have studied 138 dengue patients with various organ involvement. Abdominal pain and hemorrhagic manifestations were encountered as next most common symptom after fever, nausea, and vomiting. Liver was most common organ involved in dengue patients in the study group. Presence of
1 minute
sepsis
left.
in dengue patients is significantly associated with deaths. There was strong positive association between renal involvement and death. Patients with hepatic and renal involvement together were found to be associated with significant mortality. As world is facing global burden due to COVID-19, leading to more healthcare resources are diverted for combating the pandemic now, because of which arthropod-borne infections like dengue are re-emerging as a potential threats in near future. Vector preventive measures along with early diagnosis of dengue viral infection, monitoring for evolution warning signs, and initiation of appropriate treatment accordingly are important measures to be taken to reduce the severity of dengue in terms of both morbidity and mortality. I have the bar chart showing age and gender distribution. According to this, male involvement is more as compared to female patients. In
Sir, time up.
clinical symptoms, fever is the most common clinical feature.
Well, I think you can stop.
Thank you, everyone.
Your slide is gone. We need to have your slide.
Yes, sir. I'll do it.
Can I ask Dr. Chaudhary first?
Please.
There are 2 or 3 questions from my end. Which
Yes.
laboratory parameters you have looked into this?
Sir, to diagnose the dengue fever, there is a clinical definition. We diagnose the dengue fever according to fever with the with the 4 signs. With the manifestations like headache, retroorbital pain, myalgia, arthralgia, rash, hemorrhagic manifestations, or leukopenia, we are looking for a laboratory investigation such as dengue NS1 antigen test and dengue IgM ELISA test, dengue rapid antigen test. Also, in CBC, if there is a thrombocytopenia, it also suggests the involvement of the patient as a dengue.
So, Dr. Rahul, did you do a sample size calculation?
Yes, sir.
Did you do a sample size calculation?
Yes, sir. We did. I did the sample size calculation, sir.
It came to how much?
Sir, it came as 138.
138.
Yes, sir.
Based on what?
Sir, actually, we taken the number of patients admitted in 2016 and 2017, and there was one study. In that study, there were a total 156 patients, and the organ involvement was around 10%. So I took the prevalence as a 10%.
Okay, 10%. Now, what is the conclusion?
Yes, sir.
What is the conclusion of your study?
Sir, actually, there is a in this study we had seen the involvement of the organs in the dengue patient and the severity of the organ.
First line you have said is we have studied 138 dengue patients.
Yes, sir.
Is that a conclusion of your study?
No, sir.
Then you go on to what is all this COVID-19 and prevention, vector, preventive measures. Is this a part of your study?
No, sir.
And this has no place in the conclusion. Conclusion is basically you have carried out a study. From
yes, sir.
Study what you have concluded. So just this 2-3 line is your conclusion. The rest is all your comments or whatever you can say. This is not part of conclusion.
Yes.
See, the conclusion should be very crisp and
yes,
it should be based purely on the findings of your study.
Yes, sir.
So
yes, sir.
Please be careful in the future.
Yes, sir.
Anyway, good study. Thank you.
Yes. Thank you, sir.
We can have the next presentation.
Yes, sir. Our next presenter is Dr. Sahil Langde. Sir, could you please start sharing your screen? Dr. Sahil. Please put it on the slideshow mode.
Is the screen visible?
Yeah, it's visible.
Can I start?
Yeah.
So good evening, everyone. So the title of my study is it's a study of clinical profile and cognitive function in elderly hypertensive patients attending hypertension clinic of a tertiary care hospital. So in the background, hypertension is a well-known cause for neurological illnesses in elderly population. However, the effect of various parameters of hypertension on cognition is not well established. And the rationale of the study is various parameters affecting dementia in elderly hypertensives like education, duration of hypertension, and central aortic BP parameters are less well studied. The central aortic blood pressure, with its proximity to cerebral circulation, may correlate better with cognition than peripheral blood pressure. So the aims and objective of my studies were to study the clinical and laboratory profiles of elderly hypertensive patients coming to hypertension clinic of a tertiary care hospital, and to compare those with the non-hypertensive elderly patients. The other objectives were to study the cognitive function in elderly hypertensive patients and to compare it with that of non-hypertensive patients. And the third one was to correlate central blood pressure and related parameters with cognitive function in these patients, the elderly hypertensive patients. So the methodology was, it was a single center cross-sectional observational case control study. The study was conducted over a period of 18 months, and total 304 patients above 60 years of age attending the OPD of a tertiary care hospital were included. The sampling was consecutive sampling, and central blood pressure was taken using IEM mobilograph pulse wave analysis system. It is very much similar to our automatic BP apparatus. The assessment of cognitive function was done by two tests. First one is mini mental status examination, and the second one was Montreal cognitive assessment. The results, as we can see, the major comorbidities which we found other than hypertension in the elderly hypertensive population were diabetes mellitus, which were seen in around 38% of the population. Second common was chronic kidney disease, which we had seen in 16% of the patients, and ischemic heart disease in around 11% patients. As you can see in the lower diagram, the MMSE and MOCA scores as per gender. The first one is the gender independent score. The gender independent score shows that males have comparatively higher MMSE score than females, and the other diagrams show the age-wise distribution of the MMSE and MOCA score. So all three diagrams in all three age groups, that is 60 to 65, 65 to 70, and more than 70, shows that male gender, the male patients have higher MMSE and MOCA scores compared to the female counterparts. The mean BMI and hemoglobin were significantly higher in hypertensive patients than non-hypertensives. The mean MMSE and MOCA scores were significantly higher in males than females, with the p-value
1 minute left.
The MMSE and MOCA score increased significantly with the level of education, as we can see in the diagram. The MMSE and MOCA scores correlated with duration of hypertension. The central diastolic blood pressure has significant positive correlation with MMSE. Pulse pressure had negative association with MMSE and MOCA scores. So in conclusion, male sex, central diastolic blood pressure, and education level are positive determinants, while female sex, central pulse pressure, and pulse wave velocity are negative determinants of cognitive function in elderly hypertensive patients. Thank you.
Dr. Joshi, can start.
Yeah. Have you taken ethics committee permission for the same?
Yes, sir. Yes, it was taken, sir. It was taken as it was non-invasive intervention, but it was taken. The permission was taken.
And how did you calculate the sample size? I mean, that figure of 304.
Yes, sir.
Can you explain?
Yes, sir. So actually, by studying the literature, the prevalence of dementia in elderly hypertensive population was around 20 to 29%. So there were multiple studies in that range. So we took the nearest population. It was a Chinese study, and the prevalence was around 28%. So with that prevalence, adjusting to our population of around 2,000 patients attending the hypertensive OPD of our hospital, tertiary care hospital. So the at a significance level of 5%, we calculated the sample size, and it came to be 230%.
Actually, I've not clearly understood what do you mean by this positive determinant and negative determinant. Can you explain?
Yes,
I mean, you want to say it's more common in males than females, cognitive decline?
No, sir. The positive determinant of cognitive functions. So I had mentioned the determinants of cognitive function. So having a male sex, having a higher central diastolic blood pressure, and having higher education levels, these are positively related with cognitive function in elderly patients. While having a female sex in elderly population, having a higher pulse pressure, are negatively correlated with the cognitive function. So as males have greater cognitive, but there might be some bias in our study because a major of the male population coming to our hospital might have been more educated than the female counterparts.
So which is more accurate? I mean, the central DBP or the pulse wave velocity or the central pulse pressure? So which is more considered into account?
Sir, actually everything has a different part in the pathophysiology. So the diastolic blood pressure is the continuous perfusion pressure, while the pulse pressure is a variation. So that's why I think we think the rationale behind the conclusion was the more the variation, the more it will hamper the cerebral parenchyma, the brain parenchyma in elderly population, while the constant flow at a higher level might be beneficial. There are difference of opinion among the literature. Some of the studies say that the diastolic blood pressure is a negative determinant, but in our study, we found that central diastolic blood pressure correlated positively with the cognitive function in our population.
Okay, over to Chaudhary sir.
So, Dr. Sahil,
Yes, sir.
What are the limitations of your study?
Sir, first, as I mentioned before, so the first limitation was the study was hospital based and it was not community based. So we can safely say the people who are above 60 years of age coming to hospital, though these are more well versed with their own health, and these are more aware about their health. So their cognitive function might be higher than those who are sitting at their homes. So more community-based studies are necessary to check the cognitive decline with the hypertension parameters. That might be the first limitation, sir. The another limitation is as per the gender, the education level changes in our population, sir. So that is another limitation which we might need to take into consideration.
Any other? See, chronic kidney disease, IHD, diabetes mellitus, can they affect cognitive function?
Yes, sir, definitely, yes.
Then approximately, I do not know, there might be comorbid, but 38% had diabetes, 15% had kidney disease, and 11% had heart disease.
Yes, sir.
50% were having comorbidities, which independently can affect cognitive functions.
Yes, sir. Yes.
So that is a major limitation. You see, your hypertensive patients is 50% approximately.
Yes, sir.
That is a major limitation. The second thing, you see, male sex. Before you say male sex, you should have checked the education level. Unless the education level of male and females is comparable, it is that higher education level, and anyway, you also found the same thing, is a positive determinant. So if the males were having more education, then it is not the sex, but it is the education which is responsible for the positive determinants. Of course, I don't know the details. You can check up that thing.
Yes, sir. Actually, sir, it is not mentioned here, but the education levels, there was no significant difference which we found. But we think on a community basis, there might be significant difference between the strata from which they came.
Right.
Yes.
Good study. Thank you.
Yes, sir. Thank you so much.
So our next participant is Dr. Shruti Shetty. Dr. Shruti, could you please start sharing your screen?
Yes. Sorry, 1 second. Can you see my screen?
Yeah, your screen is visible.
Good evening, sir. My topic for today is the effect of omeprazole in treatment of early onset preeclampsia. Preeclampsia is a multisystemic disorder specific to pregnancy and puerperium, which manifests by 20 weeks of gestation and it resolves by 12 weeks postpartum. Omeprazole is a proton pump inhibitor primarily used for treatment of gastric reflux. Now, it encounters 3 key steps in preeclampsia pathogenesis by strongly decreasing the release of anti-angiogenic factors such as soluble FMS like tyrosine kinase, soluble endoglin 40, upregulating heme oxygenase, which is a key cytoprotective enzyme, which is a potent antioxidant action in cells. It reduces the endothelial dysfunction, which is the main cause of preeclampsia. To examine now our aim and objective, to examine whether 20 milligrams of omeprazole can safely prolong gestation in women with early onset preeclampsia, that is between 26 to 31.6 weeks, compared to the expected management alone. Now, ours was a randomized prospective comparative controlled clinical trial, which was conducted over a period of 2 years. 86 pregnant women were selected, which were diagnosed with preeclampsia, where their BP was more than 140 by 90. Proteinuria was on dipstick test, there was +1, and they were between the gestation age of 26 to 31.6. Now, we calculated the sample size using a sample T test, and whereas we had used which came down to a sample size of 86, and we divided them into two groups randomly using a SS 9.2. So we checked for age, gestational age, gravity, parity, number of abortions, randomly divided them using the software. Then we divided two groups. So one group was given standard treatment, one was given standard treatment with omeprazole. Maternal, fetal, and neonatal outcome was evaluated. Results: comparison between the two groups were carried out by a student unpaired T test. For example, for a numerical normal data, total number of patients included in the study is 86 actually, and 43 patients were given standard treatment, and the other 43 was given standard treatment with omeprazole. In patients on standard treatment, 30 patients had IUGR, 13 did not have IUGR. Whereas in those with omeprazole and standard treatment, 29 had IUGR and 14 did not have IUGR. The average birth weight of neonates delivered to patients on standard treatment was 1.66 plus minus 0.51 kgs, and the average birth weight of neonate delivered to patients on omeprazole with standard treatment was 1.64 minus 0.53. The average Apgar score of neonates delivered to patients on standard treatment was 6.93 plus minus 1.33, whereas the average Apgar score of neonates delivered to patients on omeprazole and standard treatment was 7.39 plus minus 0.95. Now, 33 neonates required NICU admission delivered to patients on standard treatment, whereas 27 neonates required NICU admission delivered to patients on omeprazole and standard treatment. Now,
1 minute left.
Significant difference between the two. So now in patients which now in maternal complications were, the incidence of maternal complications were less in compared to the ones which were given just standard treatment compared to the ones which were given standard treatment with omeprazole. Especially if you can see in this table, PPH PPH ka percentage is 2.3, and ICU admission is also less in patients who are given standard treatment with omeprazole. Now our conclusion: currently the only treatment of preeclampsia is delivery, but at extremely premature gestation, this subjects the neonate to risk of significant mortality and morbidity. Treatment with a proton pump inhibitor in the late second trimester and early third trimester, which is well after organogenesis occur, is likely to have negligible risk causing fetal anomaly and adverse perinatal outcome. It can be an affordable, safe treatment to hamper disease progression and hence improve both maternal and neonatal outcome. There was no statistical significant difference between the two groups. However, neonatal and maternal outcome was slightly omeprazole. Thank you, sir.
So, Dr. Shruti, was it a single blind study or double blind?
Sir, single blind, sir.
So the patients were aware that which drug they are receiving, standard of care or omeprazole?
Sir, we had to, those who we were giving omeprazole, we had to tell them that what we were giving, and there were no side effects, and it would improve the perinatal outcome. We wanted them to believe the group that we were treating.
What is the standard of care? If you can, you just tell me in the short, what is the standard of care that
yes,
you have?
Once we've diagnosed a patient with preeclampsia, so complete bed rest, then left lateral position, 12-hourly pulse and BP monitoring, sir. Then after that, we have to do we have to do an NST twice weekly and a USG every week. Also, DFKC is given to these patients, sir. And if BP is more than 160 by 110, then we will start them on Labit, sir, between 100 to 600 mg, sir.
So the same things are repeated even for the omeprazole group?
Yes, sir. So we give them this standard treatment. Also, we start them on omeprazole 20 mg.
So your one group had a labetalol and other had omeprazole, if I'm not wrong.
No, sir. If the BP is more than 160 by 110, then. But sir, in our study group, it was an early onset preeclampsia. Before 34 weeks, we had taken. We had taken that.
How was omeprazole administered? How was omeprazole administered? Intravenously or how was?
Orally, sir. Orally.
It is given orally.
Yes.
And 20 milligram once daily.
Yes.
For how many days?
Sir, the minute they were diagnosed with preeclampsia, we started them at 26 weeks, and we followed them up till term, and post delivery also, because we wanted to see if there is any neonatal outcome. What was the neonatal outcome if there was? We also wanted to. We've seen that also in our studies.
Because the rationale of selecting omeprazole is not very convincing to me. I mean, you have mentioned 2 or 3 points. But will a single dose of omeprazole good enough to, prevent complications of preeclampsia? So, I'm leaving it to you, but I need more justification for using omeprazole as your test drug.
Sir, there was a study. Actually, we during the ethical clearance also, we had some difficulty to get the clearance for this. So we had quoted few studies, sir. Onda, there was one study done by Onda. He did a meta-analysis to prove that there is no side effect as such of omeprazole if used in pregnancy. This was one. And then there was one person called Gil O'Brien. He had used omeprazole, sir. This proton pump inhibitor, he had used it in pregnancy, and his also, sir, there was not significant difference, but maternal complications were less, sir, like ICU admission, and was less, sir.
Okay, over to
slightly the
Thank you.
Dr. Shruti, your conclusions are also the same, that there was no statistically significant difference.
Yes, sir. Yes, sir.
Okay.
But slightly, sir, the outcome was better, sir.
We grant you that.
Which was given standard treatment.
We grant you that. Now, this, you said 86 subjects were randomly assigned to 2 groups.
Yes, sir.
And
no, sir. Actually, 86 patients were selected, out of which they were randomly assigned using an SAS 9.2, sir.
Fine. I do not know what is the SAS, but please understand. Fine. Now, I don't know. That is what I do not know the details of that software, but it is common sense. See, randomly means every person has a chance of going to either group.
Yes, sir.
You can do it on your own sometime when you are free. You can take 50 chits.
Yes, sir.
25 you write 1 and 25 you write 2, mix them up, and you pick up one by one. The 2 groups cannot be equal. You can, unless you there is some the software has been told that the groups should be equal. Random assignments will not give you equal groups. Very unlikely.
Sir, the number of primigravida and multigravida in both groups differed. So the number of primigravida were 25 in one, in the second group was 22. So that difference was there.
Primigravida was there, but I'm saying the total number, because yesterday also we had another presentation the same way. So either there is something wrong with the software.
Yes, sir,
must be means you must be ordering that each group should have equal number.
Equal number of.
I do not know exactly the software, but random assignment, usually it is unequal. Right? But anyway, you have made a lot of effort. Good study.
Can I ask one question? Dr. Shruti, can I ask one question?
Yeah. Yes.
Was written informed consent taken from all the patients?
Yes, sir. Yes, sir.
And how was the consent process? Was it video recording or how was it? I mean,
So we took a written, like we had our own consent. We had a written consent, sir, like a printed consent we had in our hospital. So first we would verbally explain it to them, and then we would take a consent from them, sir.
So it was taken
And
in
we had
English
also
or a regional language?
all three languages, sir.
All three.
Whichever language
Okay.
best understood them by them, that was first presented, followed by which we had taken a signature on English, Marathi, Hindi, all three, sir.
And that consent, or along with that consent, was she informed about the possible side effects of omeprazole and the alternatives?
Dry mouth, nausea, vomiting. So we had explained, sir.
You will explain. And the alternatives?
Yes. Sorry, sir?
The alternative, that even if she doesn't take, you are not only supposed to tell about the side effects of the treatment or the good effects of the treatment, you are also supposed to tell the alternatives. You see, she could have continued without omeprazole.
Yes, sir.
And the outcome may not have been different. That also, that also should be told. Anyway.
Yes, sir. Yes, sir.
Dr. Joshi, any other questions?
Yeah, and your references, it would have been better if you could have added latest references, say last 5 years or last 10 years. Your references are relatively old.
Yes, sir.
So maybe that could have generated more interest if the references would have been latest. Thank you.
Thank you, sir. Thank you, sir.
Thank you.
So our next participant is Dr. Vikas Kumar Patil. Dr. Vikas Kumar, could you please start sharing your screen? Dr. Vikas Kumar.
Dr. Vikas Kumar, you can unmute yourself and
Dr. Vikas Kumar, could you please unmute your mic?
Sorry to say that, but I'm not able to unmute my sitting in my Zoom app. Can you please open my presentation? I have already sent to you.
Yeah, sure. शेयर स्क्रीन नहीं किया है.
Good evening, everyone. Sorry for the inconvenience. My topic for today is the study of the clinical and laboratory profile of patients with diabetic kidney disease and correlation with other complications of diabetes mellitus. Now, the introduction part. Diabetic nephropathy is a major microvascular complication of diabetes and the leading cause of end-stage renal disease, that is ESRD, globally, causing high mortality and morbidity in the patient with diabetes. Now, my aims and objectives are to study clinical profile of patients with
Rahul, slightly louder.
okay, that's sorry. Uh, to study clinical profile of patients with diabetic kidney disease. To study laboratory profile of patients with diabetic kidney disease. To study comorbidities like ischemic heart disease, hypertension, hyperuricemia, and associated microvascular complications like diabetic retinopathy, diabetic neuropathy, and cardiomyopathy. Materials and methods. We conducted cross-sectional observational study on 81 diagnosed cases of diabetic kidney disease in tertiary healthcare center. The study lasted for 18 months after ICI approval. Results and interpretation. The majority of the patients had duration of DKD between 2 to 5 years, and that of DKD was 22.82 plus or minus 19.28 months. Many patients' comorbidities were hypertension among 86.42% subjects, ISD among 37% subjects, CVA among 13.58%. The commonest finding was pedal edema, that is 61.73% subjects, followed by breathlessness, oliguria, and vomiting, which is present in 18.52% cases, and also there is skin involvement in 12% cases. The diabetic retinopathy, seen among all subjects, followed in decreasing order by diabetic neuropathy among 53.09% subjects, ISD among 37.04% subjects, and cerebrovascular accident among 13.58% subjects. And also there is diabetic gastropathy and diabetic skin involvement among 4.94% subjects each. We observe positive significant correlation between urine protein and presence of retinopathy. We also observe positive significant correlation between serum creatinine level and presence of retinopathy. Conclusion. This study confirms that the progression of the diabetic nephropathy, as there is a progression of diabetic nephropathy, the other microvascular as well as microvascular complications of the DKD also increases. All patients with diabetes should be screened for proteinuria, serum creatinine, and with irrespective of the duration of the disease. That will ultimately help to identify the people at risk of developing DKD and to develop appropriate strategies for the prevention and management of DKD. Thank you.
Yeah, I have one or two questions. You have not defined your inclusion and exclusion criteria. It's not clear that which patients you have included, which patients you have excluded. What is the age group, whether you have taken type 1, type 2 diabetes, or
Yes, sir. Yes, sir. Actually, my
only
inclusion
type 2
criteria.
diabetes?
Yes, sir. I will mention. My inclusion criteria is age between 18 to 70 years of people, both male and female, and but particularly patients of type 2 diabetes mellitus with diagnosed diabetic kidney disease as per the diagnostic criteria. My diagnostic criteria for diabetic kidney disease in this study was persisting severely elevated albuminuria, that is greater than 300 milligram in 24 hours, or albumin to creatinine ratio, that is greater than 300 milligram per gram. confirmed in at least 2 to 3 samples. Also, there is presence of diabetic
So
retinopathy.
that is fine. I got your point, but at least the important one should have been highlighted on the slides.
Yes.
Yeah, is it clear?
Yes, sir, yes.
And one more thing, you have looked into microvascular complications and macrovascular also, because
Yes.
your conclusions also mentioned about macrovascular complications,
Yes,
and
sir,
your
yes.
introduction you have mentioned only about microvascular. So are you studying both or only micro or macro?
It's both for micro and macro as well.
Okay. And what laboratory profile you have studied? What
So,
parameters of assessment you have done? If you can recollect and quickly tell me. Laboratory profile you said, no, in patients with diabetic.
yes, sir, yes, sir. In laboratory profile, sir, we have studied the hemoglobin levels. That was mean hemoglobin level found to be 9.65 gram, while the TLC count was found to be 8,700, with mean platelet count of 2.56 lakhs per cubic mm. With there is also 24-hour urinary protein level with mean value of 1,323 milligram in 24 hours.
So have you done all this in your study? Have you?
Yes, sir. Yes, sir.
Or you're just telling me the theoretical part? Have you actually done all this? I mean, or looked into all these parameters?
Yes, sir. I have looked into the parameters.
Okay, and there are no references on your slides, so it would have been better if you would have quoted some references. Have you taken a ethics committee approval from
sir.
KM Hospital EC?
Yes, yes, sir. Yes, sir. We have taken it.
Okay, so it is always better to mention all these things at least in one line or two lines on the slides for better understanding. Over to Chaudhary, sir. Yeah.
Did you do a sample size calculation?
Yes, sir. In my sample size calculations, the prevalence was found to be around 30 to 40%. With this, I have put this sample prevalence in my inclusion criteria. Then it came to the 81 cases around.
With 30%?
Yes, sir, but my inclusion criteria was slightly different, so that it came to the only 81.
I don't know, because with 30%, it should come to much higher. Anyway, now second part is, see, conclusion is supposed to be conclusion of your study. You start off with confirms. The conclusion is supposed to be what you have found, and from that what you conclude. And then you go on to say all patients with diabetes should be screened for proteinuria. Now, you see, this is not based on your study. Isn't it?
Yes, sir.
This you can say possible recommendation. This cannot be your conclusion. Based on what you have studied, the conclusion should be just that. Right?
Okay. Yes, sir, yes.
I think the rest points Dr. Joshi has covered. You should have mentioned, the sample size, because sample size of 81, that means very low prevalence, not 30%. Anyway, well done. Thank you.
Thank you, sir.
Our next participant is Dr. Yash Sharma.
Hello, am I audible?
Yes, you are audible.
Yes,
Could you please start sharing your screen?
Yes. Is it visible?
Yeah, it's visible. Please put it on full screen mode. Yeah.
Hello, everyone. This is my study. It's clinical profile and short-term outcomes of patients admitted with acute pulmonary embolism in a tertiary care hospital. Acute pulmonary thromboembolism is defined as an occurrence of sudden thrombus in the pulmonary vasculature, either in the pulmonary trunk, the main pulmonary artery, or its branches. Most commonly, the origin is from a thrombus lodged in the deep veins of the leg, most commonly the femoropopliteal veins, followed by the iliac veins. The rationale of the study was that the incidence of acute pulmonary thromboembolism is estimated to be very high, 10 million cases per year, and it contributes to roughly 50 to 20,000 deaths per year in the hospital, secondary to acute coronary syndrome as a cause of sudden cardiac death for patients who present in emergency, ICU, as well as hospital wards. One of the major causes of death in such patients was a delay in diagnosis and subsequent treatment. We tried to study the clinical profile as well as their outcomes in order to find out if we could have an algorithm for early diagnosis and treatment for this. Our aims and objectives, the primary aims and objectives was to study the clinical profiles of patients admitted with acute pulmonary embolism, to study their laboratory profile and the radiological profile of such cases, to study the etiology and risk factors of these patients, the treatment that they were given, and the outcomes of these patients which were admitted with acute pulmonary embolism in a tertiary care hospital. Our study was a single center, prospective, observational description study. Total 31 patients who were attending the emergency medical services or who were admitted in the medical ICUs and wards and developed this complication were studied and were followed up at day 30 and 3 months after we gained approval from the IEC committee. We assessed their presenting complaints, their clinical examination findings at the time of presentation, their laboratory findings, their radiological findings, and after that we came to our conclusion. Our results were that the mean age of patients diagnosed with acute PTE were around 50 years of age. Past history of hypercoagulability, that is DVT, pulmonary embolism, or cerebral venous thrombosis was found in around 32% of the patients. Past history of fractures, immobilization, major surgery, lower limb swelling was found in nearly half of the patients, 45% of the cases. 2 cases are active COVID-19 infection, and one of them was a case of post-COVID-19 infection. Post-TB sequelae was seen in 2 cases, and active pulmonary tuberculosis was found only in 1 patient. Lung cancer, that malignancy, was found in 1 patient. 9 cases had no comorbidities and no risk factors. 5 cases had significant smoking history, while 7 cases had significant alcohol history. The day 1 symptoms included sudden onset breathlessness in around 90% of the patients, that is 28 cases, followed by chest pain in around half of the patients, 45%. Cough was present in around 13 cases, that is 41%. Just leg swelling was found in 10 patients, 32% of the cases, and hemoptysis was a rare symptom found only in 4 cases, that is 12%. ECG findings, the most common finding
1
was
minute left.
Most common finding was sinus tachycardia in 22 patients, that is 70%, and the classical S1, Q3, T3 were found in 3 cases. Chest X-ray demonstrated pulmonary infiltrates in nearly half. However, normal chest X-ray was seen in 9 patients, that is 29%. USG Doppler showed normal USG in 64%, unilateral DVT in 9%, and bilateral in only 6%. 2D echo showed RA, dilatation of RA and RV in only half of the patients, whereas normal report was found in 14%, or nearly half again. Major vessel embolism was found in 51% of the patients. Out of all our patients, 4 of them received thrombolysis, 27 received secondary anticoagulation, none of them were taken for surgery. Mortality was 3 cases. The most common complication was secondary pulmonary hypertension. What I would like to conclude is that prolonged immobilization as a risk factor was found in nearly 45%, that is half of the patients, which warrants prophylactic anticoagulation. Almost all of them gave hospitalization history in the past 3 months, which again
Time up.
warrants prophylactic anticoagulation in those patients. Thank you.
Yeah, actually, I have 1 or 2 questions, Yash.
Yes, sir.
I felt your sample size of 31 is too small to arrive at a conclusion.
Sir, actually, we actually had a reference article where in Indian population and hospital acquired in the hospital, the patients who were admitted in the hospital, our prevalence was found to be only 5.8 to 6.2%. According to that, the sample size was calculated to be only 31 patients. Sir.
Okay, but your conclusion again is not in sync with your aims and objectives, because you have looked at to clinical profile, laboratory profile,
Yes,
radiological profile.
Yes, sir.
And
So out of that, we actually wanted to find out that since in acute PT, which is also one of the causes of mortality, if there was any risk factor that was found in majority of the patients. Sir, actually, out of this, the most commonly found risk factor was actually a history of either immobilization or fracture or a major surgery, which was there. So that was the most common risk factor that was found.
And what actually short-term outcome you have looked for? It's not
Yes, sir.
clear.
So,
The title says short-term outcomes.
yes, sir.
So which
So,
are those outcomes
yes,
that you have
sir,
looked?
the pie chart actually shows there that mortality was found in only three cases, whereas nearly 12 cases did not show any complications or had probably good outcomes, whereas around 10 of the cases actually developed pulmonary hypertension, which was assessed at 3 months with a repeat 2D echo. And sir, arrhythmia was only found in one patient. He was one of the patients who succumbed out of the 3 patients who had succumbed.
What statistics you have applied in this?
Sir, we've actually used Pearson's equations for statistical analysis.
Okay, and you have a lot of descriptive data also, no? Parameters.
Yes, sir. Yes, sir. Sir, for that we had used the chi-square analysis.
Okay. Again, your references, I felt that they were too old. You should have at least included last 5 years, 7 years references.
Yes.
And it's okay from my side. Over to Chaudhary, sir.
No, Dr. Joshi has covered all the points.
Yes.
I think we can move to the next.
Thank you.
Our next participant is Dr. Harsha Kadam. Could you please start sharing your screen?
Good evening, everyone. My topic of the poster is prevalence of anemia and gynecological disorder in adolescents. I'm from MGM Medical College, Panvel. Adolescence is divided into 3 stages by UNICEF. Early adolescence is 11 to 13-year-old, begins with puberty and with the transition out of the childhood. Middle adolescence is 14 to 16 years, and late adolescence is 17 to 19 years. It's a stage of transition into adult roles. One of the most serious adolescent issue is anemia, which is defined as low blood hemoglobin concentration and a severe public health issue. It primarily affects underdeveloped countries and has serious negative health repercussions, including morbidity and mortality. It also has negative consequences for social and economic growth. Iron deficiency anemia is the most frequent nutritional deficiency disorder in the world, as well as the most common cause of anemia. It is usually characterized by a defect in hemoglobin synthesis, which results in red blood cells that are abnormally smaller in size, which we call as microcytic, and they have significant decreased amount of hemoglobin, hence called hypochromic. Regions like Asia and Africa have a higher prevalence of anemia. The most important cause of anemia in the world is nutritional deficiency. Kishori Shakti Yojana, Balika Samriddhi Yojana, Rajiv Gandhi Scheme for Empowerment of Adolescents Girl, Rashtriya Kishore Swasthya Karyakram and Adolescents Reproductive Sexual Health Program, ARSH, are among the many healthcare programs in India run by various ministries to address the problems of adolescents. My aim and objective of this poster was to study and evaluate anemia and various gynecological problems encountered in adolescents' birth. Prevalence of anemia in female adolescent patient, prevalence of gynecological disorder in female adolescent patient. The present study, prevalence of anemia, was conducted in the tertiary care center, prospective observational study done in 250 adolescent girls between the age group of 11 to 19. India is a developed country and about 80% of the people live in rural area. Majority of the population comprised of low socio-economic status. Indian cultural attaches great importance to Matru Deva Bhava, which is saying in a Sanskrit that equates mother of the god. Today, the health status of Indian women and girls is at a terrible position due to the complex interplay of the socio-economic, cultural, and political factors. Several Indian surveys and studies have concluded that a large number of adolescent girls have very poor nutritive status, low BMI, and caloric deficit. Remains anemia and cause tremendous delay in seeking medical help. Though there are various factors that contribute to the prevalence of anemia, the current study has helped narrow down the major contributions such as literacy, status, age, anthropometry, and associated gynecological disorders, especially menstrual disorders. The following factors that contribute to the high prevalence of anemia among adolescent girls: increased iron requirement due to growth, menstrual loss, discrepancy between high iron requirement for hemoglobin production and poor intake of iron, iron absorption inhibitors in phytates, tannins, eating factors, aversion for food high in iron such as green leafy vegetables. Symptomatology among female adolescent patients showed majority of girls having more than one presenting complaint, with menstrual disorder being the most common gynecological disorder.
1 minute left.
in 180 patients. This ranges from amenorrhea to menorrhagia. Complaint of generalized weakness. 66 patients presented with vaginal discharge, 31 patient presented with abdominal pain, 27 patient had urinary complaints, 45 patient had complaints of acne of hirsutism, while only few had pica. Anemia was found in had pica. Anemia was found in 81.2% among female adolescent female. A higher incidence of anemia was also found in early adolescent age group, followed by late adolescent age group. Only a small percentage of adolescent girls visited the hospital for medical reasons is the conclusion. Anemia was found to be alarmingly high among those adolescent girls. Age, literacy, socioeconomic status, BMI, dietary habits, and associated menstrual dysfunction were found to be pivotal in the occurrence of anemia. Anemia is the most common in the underweight adolescents, while PCOS and oligomenorrhea were predominantly over the overweight adolescents. The knowledge of anemia, significance of iron-rich diet, prophylactic iron therapy, and deworming was significantly low.
Time up.
Okay, thank you.
I have one or two questions. What is the reason that you have taken both anemia and gynecological disorders? Because these are two totally different, conditions. So, is there any reason for taking them together and doing the study?
So actually, adolescent is the age group which presents with different major different diseases. So as such, we wanted to do a group study in them. We wanted to see the prevalence factors regarding anemia as well as other gynecological factors like menstruation disorders and everything.
Okay, I felt you could have done this as two different studies rather than clubbing into, because there is no connect that way between anemia and some of the gynecological disorders that you have talked about. Another thing is, have you taken ethics committee permission?
Yes, sir.
Because some of the patients are minors. I mean, the data you have collected is some of the minors. So, I mean, has EC allowed you to access those records?
So we have taken the permission of the parents. Only the patients who are billing, we have included them in the study, sir. I didn't mention the inclusion criteria, sorry, sir. But in the inclusion criteria, we have only taken the patients who are billing for the study.
But have you taken only consent or you have taken assent also? Because your age group is 11 to 19 years. So some are minor, some are above 18. They can be considered as adult enough to give the consent. So I'm asking, have you taken assent? You know what is the definition of assent?
Taking the consent of the parents included.
It's an observational study, I guess. Okay.
Yes, sir.
So you are gathering, the information from the records. There is no direct face-to-face interview, no?
From the records.
Again, your inclusion exclusion criteria are not clearly defined, so I'm not able to make out like what you have done during recruitment. Anyway, over to Chaudhary, sir.
Sure. I have just two observations. One is, you see, I think this conclusion you have mistakenly written here, it looks more like discussion. Conclusion should be consistent with your aim: prevalence of anemia in female adolescents, prevalence of gynecological disorders. Full stop. You have written everything. Implementation of initiatives such as ARSH. This is not your conclusion.
Okay, sir.
These are comments.
Sorry, sir. Yes.
Or you can do advice, but conclusion should be very crisp. It is the essence of your study.
Yes.
And lastly, I can't make out properly, but I think some of the references are of 91 or something. They're very old. This is a very common topic. I'm sure you will get much more recent references. I think the third, fourth, these are all of 1990s, isn't it?
Yes, sir.
So please avoid, very old, 30-year-old references are not very reliable. You must have more recent references, right? Anyway, well done. Thank you.
Thank you, sir.
So our next participant is Dr. Suvarna Dhom. Dr. Suvarna, could you please start sharing your screen?
Yes. Am I audible? Hello.
Yes, you are audible.
Good evening, everyone. I am Dr. Suvarna. My topic is clinical profile of non-alcoholic fatty liver disease and its correlation with metabolic syndrome and cardiovascular risk. The term non-alcoholic steatohepatitis.
Dr. Suvarna,
Hello. Yes.
there is some disturbance from behind.
The audio is not clear.
Hello.
Yes.
Am I audible?
Now you are audible.
The term non-alcoholic steatohepatitis describes liver histology distinguishable from alcoholic hepatitis in patients consuming significant quantities of alcohol, more than 40 grams per day. Non-alcoholic fatty liver disease is a broad term and including patients of only steatosis and non-alcoholic steatohepatitis. So steatosis is a deposition of adipose tissue in the liver and which leads to the more progressive fibrosis, cirrhosis, and hepatocellular carcinoma. Several studies have tried to quantify the NFLD incidence, in which Western countries found that there is a 20 to 30%, and in Asian studies, the incidence was 5 to 10%. The aim was to elaborate the clinical presentation of the disease in an urban Indian setting to better understand the incidence of diabetes mellitus, hypertension, and metabolic syndrome among patients of NAFLD, to correlate findings with the internationally accepted metabolic syndrome parameters, to study the complication associated with disease in all its stages. So the study followed a prospective observational model and was conducted over a period of 2 years in the tertiary care hospital and according to the IEC protocol. Total 80 patients were participated. Those who are attending OPD and indoor under general medicine and the gastroenterology, patient diagnosed with NAFLD were investigated for the metabolic syndrome according to the NCP 86 criteria. So, according to 80 patients, the fatigue, pedal edema, abdominal pain, jaundice, hepatomegaly were seen in 35%, 31%, 40, 36, 48% respectively. In this study, we have found that participants with metabolic syndrome were significantly more symptomatic than those without metabolic syndrome. 45% of the patients were of fatty liver grade 2 by 26% and 28.75% of the patients were fatty liver grade 1 and grade 3 respectively. Metabolic syndrome was found to be present in 72.5% of the patients. So the pie chart was showing the metabolic syndromes with NFLD. So around 72% were showing the metabolic syndrome, and the first bar diagram was showing the age-wise distribution. So mean age was found to be 33 to 57 years of age, and the last bar diagram was showing the comorbidities associated with the NFLD. So it was found that 43% were diabetic, 42 were hypertensive, 37 were dyslipidemic, and 5% were CKD and ILD. So my conclusion is that higher prevalence of all the components of metabolic syndrome in case of NFLD was observed, and liver biopsy was considered the gold standard for diagnosing NFLD. The significant association of NFLD with high fasting blood sugar level, high triglycerides and cholesterol, and low HDL demonstrate a corresponding increasing risk of cardiovascular.
1 minute left.
Thus, the patients must be evaluated for the prevalence of NFLD in the presence of metabolic risk factors. Early detection would help in modifying the disease course and delaying its complications. Thank you.
I don't have any specific comments on the paper. Over to Chaudhary sir.
Just 1 or 2 points. One is this, see, your conclusion.
Yes, sir.
Liver biopsy is considered gold standard for diagnosing NAFLD. This is based on your study.
No, sir.
So this should not be in conclusion.
Yeah.
Is it?
Yes.
Just see, conclusion should be what you have seen, and from that what you have concluded.
Yes.
Everything else you can put, this is all to be put in the discussion. Then your reference is incomplete. First reference is incomplete.
Okay.
Then did you do a sample size calculation?
Yes, sir. So total patients were 81, and according to Asian studies, it was around prevalence was 5 to 10%.
Okay. Right. Well presented. Thank you.
Have you taken ethics committee permission for the
Yes,
same?
sir. Yes. Yes, sir.
It would have been better if you would have quoted the approval number.
Yeah. Okay. Yes, sir.
Nothing else. Thank you.
Thank you, sir.
So it was our last presentation for the day. Thank you both the judges for your valuable time and expertise.
Thank you.
Hawra on very well conducting the presentation.
Thank you, sir.
Dr. Sirish, nice to have met you online. Hope we can meet sometime actually.
Thank you for having with us.
Hawra, I'll mail you that mark. Huh?
Yes, sir.
Okay.
We will mail you by tomorrow.
Okay, sir.
Thank you.
Thank you.
Thank you then.